Hello and welcome. I'm Tiffany Baldwin, an employment immigration attorney in Husch's Healthcare, Life Sciences, and Education Business Unit. That's a mouthful. Before we begin, I'd like to cover a few housekeeping items if you didn't see the slides before. At the bottom of your audience console, there are multiple application icons for your use during the program today. If you have any questions during the webcast, please submit them via the question box. My kind colleague, Kelly Miley, will be monitoring the questions, and I will try to answer all the questions at the end of the webcast today. But if a fuller answer is needed or we run out of time, it will be answered later via email. A PDF of the presentation is available in the program materials folder. This program has been approved for legal education hours. If you are joining us live, you can report your hours by clicking the CEU icon at the bottom of your screen. Tomorrow, you'll receive a certificate of attendance and a recording of the webcast for watching and sharing with colleagues who couldn't join us today. We'd appreciate it if you could complete the short survey at the end of the program. Your feedback will assist us in planning future programs that are applicable to your business needs. That's all for the housekeeping items. Let's get started with the program. As a daughter of an immigrant, it's no surprise I ended up practicing immigration law. But it was my first case as a little baby law clerk that led to the next 25 plus years focusing not only on employment immigration, but in the niche area of physician and healthcare immigration. That case involved a USDA physician waiver. That program no longer exists, but many others have taken its place, and we'll discuss them today. I spent my career working with hospitals, health systems, and staffing and practice management companies throughout the United States on immigration processes for foreign physicians and healthcare workers. So there's a lot of content here. So this will be the first of several webinars relating to the use of the immigration system as a recruitment and retention tool, and to identifying where your organizations can best use immigration to meet your staffing needs. Today, I will focus on the challenges presented by J1 physicians subject to the 2-year home residence requirement, and, time permitting, H-1B physicians. I try not to play favorites with my cases, but I really love cases involving physicians because it is a win-win-win for the physicians who get to continue their career in the United States, the healthcare employers who can fill their openings in a world of growing physician shortages, and most importantly, the patients who are now able to access the care they need in a timely fashion. But I get it. Dealing with immigration issues often scares organizations. There's various pathways and they're complex, and it can all seem very daunting. So my aim today is to demystify the process and give you an understanding of physician immigration so you can create a strategy and develop a recruitment plan. Over the years, I found that recruitment teams and healthcare organizations who are knowledgeable on physician immigration issues have a competitive advantage when recruiting physicians. So today, I'm going to start off by talking a little bit about the physician shortage and where we see foreign physicians currently in the United States. I'll give you a basic primer on immigration law and foreign physician clinical training, and then I'll move on to the big kahuna of physician immigration, the J1 waiver of the 2-year home residence requirement. And if time permitting, we will briefly talk about physician H-1Bs. We'll end the hour with your questions and let you know what we'll be discussing in the future webinars and blog posts. Now, I'm sure you've seen a lot of numbers floating around about the physician shortage. AMA has this huge range of anywhere from 37,000 to 100,000 by the end of the decade. Some have even larger. As a practical matter, what that number is 10 years from now doesn't matter when you need 2 pediatricians and a hem-onc right now. It doesn't matter how bad it's expected to be in a decade when healthcare access is a huge problem in your communities now. The urgency is today, and particularly in areas where certain healthcare issues are on the rise, where there's an increase in usage due to Medicaid expansion, and where both the patient population and the provider population are aging. I put the statistic that 50% of practicing physicians are over the age of 55. Believe me, I do not believe 55 is old by any means, but working in healthcare has gotten harder. And so for certain specialties, age is a factor. Think of a surgeon or ER doc. They retain the acumen and skill, but it's physically more difficult with age. Kind of like Jason Kelsey in the last couple seasons with the Eagles. It can be grueling. So I know that you are all looking for various ways to deal with these shortages, whether it's freeing doctors of administrative burdens, using more PAs and APMs, or developing and grow your own programs. Your efforts are multifaceted. But recruiting foreign physicians should be another tool in your bag. It's a pretty great and sustainable one. So what specialties do we see these physicians? A quarter of the physicians currently practicing in the United States are international medical grads. Now, most but not all of these IMGs are foreign nationals. Some are US citizens or permanent residents who happen to go to medical school outside the United States. In addition, foreign nationals who attended US medical schools aren't part of that number. But I feel that IMGs is data is good indicator for all foreign physicians, because the population of US that go to foreign medical schools and foreign that come to US medical schools are probably about the same, and they cancel each other out. So in this chart, you can see some, I just put some of the larger specialties where there are a lot of IMGs practicing. And there's more information about all that data in the two articles that are sourced. And so it's important for recruiting for positions, because if you know that it's likely that 1 in 3 applicants is going to be an IMG, that drives home the need to familiarize yourselves with the immigration-based recruitment and employment restrictions attendant upon hiring foreign physicians. Looking for an internist, good chance you'll get a number of IMGs applying. Looking for a geriatrician, half of the 6,000 active physicians in that field are IMGs. In addition, each year, more than 4,000 IMG physicians from more than 100 companies are sponsored in graduate medical education programs. They make up about 1 in every 4.5 residents. And again, looking at where they tend to train, you can determine where your applicant pool may come from. And this is constantly changing. 15, 20 years ago, nephrology would have been in that list of top 4. So again, these statistics are great in helping you determine if the pool of potential applicants may skew to foreign physicians. So why do they have to do international, or why do they have to go through GME training? So and to understand how foreign physicians come to the United States for training, I'm going to back up and do a little immigration 101. So in the United States, visas are divided into 2 main categories: immigrant visas and non-immigrant visas. Immigrant visas are permanent resident visas or green card visas. Someone with a green card can stay and work permanently in the United States and can eventually apply for citizenship. And I'll review pathways to the green card in the next webinar. Non-immigrant visas are a veritable alphabet soup that are limited in time, renewable, but still temporary, and geared towards a specific purpose. F1s for college students, B2s for tourists, Ps for athletes. Certain non-immigrant classifications are for employment. The primary employment visa for physicians and other degree professionals is the H-1B. 95% of the time, if you're hiring a non-immigrant foreign physician, it will be in the H-1B classification. Here's the tricky part that brings us here today: the J-1 non-immigrant visa. So the J-1 visa is a cultural exchange and training. And it's a pretty broad category. It includes au pairs, exchange students, the young adults that are working at Disney for the summer, research fellows and scholars. and those in GME programs. The key word of the J1 is exchange. J1s are to come to the United States to attain knowledge and learn techniques and skills that they will then go back home to share and use in their home countries. And that's the goal. But to prevent brain drain in these countries, there are some subcategories of the J1 where there is a requirement to return home for at least a period of 2 years before they can come back to the United States to work in H-1Bs or get a green card. J1 visas must be sponsored by authorized J1 exchange organizations. For foreign physicians who come here for GME training, they are sponsored not by the teaching hospital or the health system, but by ECFMG, which stands for the Educational Commission on Foreign Medical Graduates. That is the agency that will govern and regulate which foreign nationals can come to the United States for clinical training. And there are tests and credentialing, and I've read that it's pretty tough, and fewer than 50% of those who go through that process get ECFMG certification. So foreign physicians that are coming here on J1 are typically very well qualified. As a result, they tend to excel in their U.S. training programs and are great candidates for U.S. healthcare providers. So why do they even have to do GME training? Accredited residency and fellowship training programs are almost always needed for state medical licensure. And that's why even a physician who's been practicing for a dozen years in their home country still needs to go through a U.S. GME program. Because of the growing physician shortages, states are considering exceptions. Last April, Tennessee passed a law that goes into effect this July that will allow certain foreign physicians to bypass U.S. residency training to obtain licensure. But exceptions aside, for now, residency and fellowship training is pretty much a must. And there are two non-immigrant visa types that are typically used for training. Of the GME programs, a little less than 2/3 will sponsor J1s. Obviously, the actual sponsor is ECFMG, but they will entertain J1s. And then within the total, 22% sponsor both J1s and H-1Bs. And of course, there may be trainees in other types of immigration status, but this is the bulk of them. As you can see, teaching hospitals prefer the J1. And that is because although both J1 and H-1B non-immigrant visa classifications allow for employment of foreign physicians in GME programs, these categories differ significantly from one another in terms of the teaching hospital's role and responsibility, the required fees, administrative burdens, and the flexibility of employment of the IMG physician. So the fees involved in J1 can be borne by the foreign physician. H-1B fees are not only more than the J1 fees, but they have to be borne by the teaching hospital as one example. There are other impediments to the H-1B, such as you have to have licensure and ECF and USMLE Part 3 for H-1B. So again, most programs prefer the J1 visa. But as I mentioned, ECFMG is the J1 training sponsor, and this subcategory J1s is the one that has one of the 2-year home residency requirements. Excuse me. So the 2-year home residence requirement requires the J1 to return to their home country or their place of last permanent residence for a cumulative period of 2 years before they can obtain an H-1B visa or permanent resident status, so a green card. And it is a hard and fast rule. You got a U.S. citizen spouse, you still got the U.S. You still got the 2-year home residence requirement. U.S. citizen kids, same. Even Canadians who, because of a quirk in the language of the 2-year home residence requirement, can get an H-1B without the waiver, they still have to either fulfill the 2-year requirement or get a waiver before they can get a green card. In short, the 2-year home residence requirement is kind of like glitter. Once it attaches to you, it's kind of hard to get rid of. But for that have worked hard to get into a U.S. residency or fellowship, they don't want to return home, even for 2 years. They've made connections here, they've come accustomed to living in the United States, and maybe have started a family here. And frankly, we should want them to stay. One, the physician shortage. But two, there's a heck of a lot of taxpayer money in these training programs. And the U.S. government has an investment in these physicians, and they should want to return on the investment. And here's another thing. Everyone wants U.S. clinically trained physicians. So if they don't find something here, New Zealand, Ireland, Canada, Costa Rica will be happy to have them. And as the kind of bartender says, you don't have to go home, but you can't stay here. And so that's the J1. So it is return home, qualify for another non-immigrant status like an O1, or get a waiver. Now, there are two clinical, non-clinical ways to get waivers, and we're not really going to discuss them, but the waivers are available for those who can demonstrate that they will be persecuted based on race, religion, or political opinion if they were to return to their home country. As there's another waiver for those who can demonstrate that their departure will cause exceptional hardship. Excuse the slide, it says extreme, but it's exceptional hardship to a U.S. citizen spouse or child. The adjudication of these waivers involves a very subjective set of criteria that can be difficult to predict, have legal standards that are quite high, and often take a long time. So the third way is for a federal interested government agency or a state health department to request a J1 waiver on behalf of physicians to actively provide clinical care to underserved communities because such care is in the public interest. IGA waivers often hinge on the IMG's employment in the area within the purview of that agency. And I'm going to use IGA to refer to both the federal programs and the state programs just because it's shorter. So what are these programs? We have a little history. The VA, which we won't really discuss much here, was the first to support J1 physician waivers. And then in the early 90s, USDA and HUD began their programs. The Conrad program began in 1994. Originally, it was a 20 slot program, but a decade later, there was no more USDA or HUD programs, and so that number was increased to 30. So we have the Conrad 30 state program today. And then there are various regional commissions that offer programs, including the Appalachian Regional Commission, the Delta Regional Authority, and the Southeast Crescent Regional Authority. And there's a new kid on the block, the Northern Border Regional Commission. And so the underlying policy, again, is to expand the safety net to underserved patient populations for greater healthcare access. So there's some there's across the board rules for IGA waivers. So the federal regulations create the basic structure for these waivers, and then the individual programs kind of fill in the blanks and customize them to meet the needs of their jurisdictions or their charters, if you will. So one is that we are placing physicians in underserved areas. So there's a requirement that the location of the work be in a health profession shortage area, either geographic or population, or a medically underserved area or medically underserved population. The exception, there are a couple of exceptions. One, VA facilities, because they're not always in HPSAs or MUAs. And then for the state programs, there is something called a flex. Up to 10 of those 30 slots can be for facilities that are not located in a HPSA or MUA, but that serve populations that come from HPSAs and MUAs. Contracts must be for 3 years. The commitment to get rid of the 2-year waiver is a 3-year commitment for 40 hours a week on average. And I know they kind of work with that because not everything is a kind of 9 to 5. So it's essentially 160 hours a month. and they have to provide medical care to both Medicaid and Medicare eligible patients, indigent and uninsured patients. And there must be good faith recruiting. The facility needs to have tried to recruit U.S. physicians, but have been out of luck. And then to start the employment within 90 days of the waiver approval. Not in the regulations, but it's almost a de facto requirement because most programs have it, is that they do not allow non-competes because these programs are premised on the principle of attracting and retaining much needed physicians to underserved populations. So a non-compete provision that restricts the IMG's employment in the underserved area, both during and after 3-year services, tend to run contrary to that goal. And I know we have some questions that we're going to keep to the end, but I just want to cover it because some of these are pertinent to what we just had before. So yes, USMLE is needed for J1, but just parts 1 and 2, and the 2 parts of part 2. But for H1B, it is all 3 parts. So essentially all 4 parts, and they broke it up. And a sponsor, a petitioner for the visa category. Although again, for J1, this actual sponsor is ECFMG, but the program is within the part of the sponsorship. Okay. Okay. The timeline for J1 waiver process. So all cases start with getting a case number from the U.S. Department of State. And this number goes on every sheet of paper that is part of a waiver application. We're very specific about that. And that number follows them through the agency to the Department of State to the USCIS. So it's kind of almost like a Social Security number. It kind of carries them through. And waivers are going to be initiated at one of these interested state or federal agencies where hopefully the agency will request that a waiver be given to the J1 physician. Typically, this process, once you apply, takes 1 to 3 months. I've seen some state do less than a week, and then some specialist cases are held back until primary cares are reviewed, and so it may take longer than 3 months. But in general, these are kind of general ranges. The state or federal agency forwards the application to the U.S. Department of State, who does its review and recommends the waiver and forwards the application to USCIS. There's also a fee paid to Department of State for this process, so it's pretty minor. If a case gets held up, it's usually at Department of State, especially in the spring. So again, that's where like 1 to 3 months come into play, or 2 to 3.5 months. In March and April, that's probably closer to 3.5 months because they do get a little jammed up there. And then finally it goes, the actual approval comes from USCIS. And their process, can take maybe a couple weeks to 2 months. It's pretty variable. And so the process from initiation, not filing, but like initiating the case to when the foreign national can start work is about 7 to 10 months. And in the different color on here, I had to put the H-1B petition because, again, the J-1 just takes care of the 2-year home residence requirement. It doesn't provide employment authorization. So usually between when the Department of State issues its recommendation and USCIS issues its approval, the H-1B is filed. And so that's kind of the whole timeline for the process. Now let's get into some specifics of the programs, which is probably of most interest. And we'll start off with the Conrad 30. So again, this is administered by the state's Department of Health for each state, plus Washington, D.C., Puerto Rico, Guam, and the U.S. Virgin Islands. And again, in addition to that framework that's overarching all these programs, states are given wide latitude to craft their programs to meet the needs of their state, making Conrad programs pretty diverse. I mean, there are a lot of commonalities, but there are a lot of differences. And some of the differences have to do with how friendly they are to J1 physicians. Some programs have very practical, reasonable requirements and very efficient and accessible. And then there are those that are not. And then the employer and the physician are jumping through a lot of hoops, and they may have antiquated recruitment requirements, etc. So it's a pretty wide range. There are advantages to the Conrad programs over the federal programs, but primarily it is with the flex spots, which federal programs don't allow. So again, and we'll talk about that a little bit more. Again, non-competes, although a lot of states do have non-compete restrictions, and liquidated damages clause, which is part of some of the federal programs. Okay, so here are the variables, which you can see it's a long list. So application timing. I think at last count, about 42 of the states will start accepting applications October 1st, the beginning of the fiscal year, or within the first week of October. And some are rolling, and some have a filing window. And then the others will have an August or September filing period, so a month or 6 weeks before the start of the fiscal year. And the exception to all of those is Ohio, which opens up filings when they feel like it. Maybe it's March, next year might be April, who knows? So not very great for planning, but it is what it is. And most states will allow for subspecialists to participate within the J1 waivers. They'll take J1 waivers for subspecialists, but what that means in the state may be different. So it can mean a set aside to 5 or 10 waiver slots. It can mean that you have to wait to see if there are any slots left after they go through the primary care applications. Some also differ with what is regarded as primary care. For instance, some states, hospitalists are primary care, and some they are not. So there's, again, wide range of that. Again, because there must be care provided to Medicare and Medicaid patients and indigent patients, a lot of states will require a sliding fee scale or some sort of charity care policy that discounts low-income patients in other ways than a sliding fee scale. And then some states will focus on only having HPSAs or restricted to geographic areas as opposed to populations. Although most states will accept applications for geographic HPSAs, population HPSAs, medically underserved areas, medically underserved populations, the whole gamut. And again, similar to how they treat specialists, they may have different filing periods based on the designation or other types of tiering in priority. So it can get kind of complicated because you have like the different dates based on both the practice area and the location of the facility where they're working. Again, flex, which is a great benefit, and that is when, again, you're not in HPSA or an MUA, but the population comes from that. Some states won't entertain flex, or they evaluate it on a year-to-year basis. And so, again, that's where knowing what the state requires is important. I've had clients who came to me and said, you know, Tiffany, we put our address in that HPSA locator you sent, It says we aren't in the HIPSA in any way, but we are seeing a lot of patients from Lee and Montgomery counties, and those are the poorest counties in the state. And so we look to see if Flex is available, and we look at the payor mix to see the percentage of like Medicaid, or do a zip code analysis to look at where the patients come from to determine whether or not we can, qualify for Flex. Again, non-compete is often a requirement, but not always. And there might be other contract provisions that are beyond the 3 years, 40 hours requirements that's across the board. Oh gosh, reporting requirements. I love this because when USCIS approves a waiver application, it is technically no longer within the purview of the agency that originally requested the waiver. USCIS is also the ultimate arbiter of whether there can be a change in location or employer during that 3-year fulfillment period. Nevertheless, there are some states that require verification of employment once or twice a year, and they want to approve, give their blessing to any sort of change of employment. And so again, that varies. Thankfully, there are not a lot of states that have filing fees. Ohio, when they do accept applications, they have probably the highest fee. It's $3,571, which is an odd number. And Texas has like a $2,000 fee. So there's some that have fees, but most don't. Also varying between the states are additional requirements. So some states are very, you got the contract, you got recruitment, you got a description of the service area, you're kind of good to go. And there's others that require community support letters or significant demographic information, or, 5 attestations where you're promising everything except for your firstborn child. So, it can be kind of tedious for some of the states. The same is true for recruitment requirements. Again, they just want to see a certain period of basic good faith recruitment that follows what you typically do to recruit physicians. And then some require, contacting all the medical schools in the state, or printing print ads, which, we're in 2024 now. I don't know why that still would be the case, but again, that's what we were seeing. So now we go, this is my favorite. I love HHS waivers. Not a lot of great things came out of 2020, if you recall, but HHS waivers is one of them. It's one of the great things. They expanded their program, which used to just involve federally qualified healthcare centers, to all facilities with HIPSAs of scores of 7 or above. And I don't recall ever seeing a HIPSA score with less than 7, so I pretty much think it's all HIPSAs. And not only do I love it, but apparently a lot of healthcare employers and immigration attorneys love it because it's a very popular program. So in 2022, fiscal year 2022, they did 350 waivers. Last year, 450. I imagine it's going to be a lot more than that for this upcoming year. Now, it is limited to primary care, but that's, that frees up a lot of slots in these states for specialists. And it just really takes a lot out of the Conrad 30 pipeline, which is great. It allows even specialists to benefit because, again, there's less competition in some of these states for slots. One of the tricky parts that's about HHS is that anyone that's in a fellowship program, it doesn't really work well because you have to start within 12 months, and it's like less than 12 months, actually not within, less than 12 months from the end of the residency program. So even with someone in a 1-year fellowship program, it could get kind of tricky. And when that can end and when new employment can start. But that doesn't happen very often, and it is it's a problem that's easy to deal with because there's so many other great benefits with the HHS program. Okay. Delta Regional Authority. So we're getting to our regional commissions here. DRA is great because they cover along the Mississippi, basically from the boot heel of Missouri all the way down to Louisiana. And there's a lot of coverage there. So 200 plus counties. They do support waivers for specialists, even though priority is given to primary care physicians. But as you can see, if you can read that from the data, 75% of what they've been approving in recent years have been for specialists. So obviously they don't have that much of a problem with specialists. Recruiting for DRA can be a bit exacting. They require, some of it's typical, right? Recruitment within the last year for at least a 45-day period before offering the contract. That seems relatively reasonable on what you would typically do. But they also want to see, in addition to national recruitment, they want to see in-state recruitment and state medical school recruitment. So reaching out in an email or letters to all the internal medicine residency programs in the state. And employment needs to be targeted. So recruitment that is like general hospital needs physicians is not going to be adequate. They want ads that are kind of focused. So general hospital needs pediatricians at its clinics in Springfield and South Metropolis. But again, those are things with advanced planning. It's very easy to accommodate. Again, DRA doesn't allow non-competes. They, like other programs, may also state no other restrictive covenants, but we've had success in keeping like non-solicitation and non-interference clauses in because they don't run contrary to the aims of the J1 program. And DRA does require a liquidated damages clause, though a few, and it's there's very exact wording that has to go into a contract for that. But a few years ago, they did begin allowing parties to sign a waiver of the liquidated damages clause. And they require 3 years of patient payor data to support the requirement that you are treating all patients. So again, that's where keep a running list of your payer data. The Appalachian Regional Commission. It covers, again, it's a long skinny from New York down to Georgia and counties within that, including all of West Virginia. Here's what I'll say. Let's see. It's a very cumbersome program, to put it nicely, for a webinar. And so if there are any alternatives to going with the ARC, it would be better to go with those other programs. You already have to get a recommendation from the state health department even before applying to the ARC. Now they have started to allow applications for specialists in recent years, so that's a good change. Hospitalists are allowed, but if it's for an outside employer who staffing or manages a hospital practice, there must be assurances by both the medical facility and the ultimate employer that they're going to comply with the program. And no non-compete, no non-solicitation. They have a liquidated damages clause. They don't allow for waiving it. And then you need to post a notice that you do have a sliding fee scale in a public place. So, and like DRA, they want those 3 tiers of recruitment for at least a period of 6 months. So. My next new favorite is the Southeast Crescent Regional Commission. SCRC came out of nowhere. Up until the summer of 2022, I don't think most people knew this regional authority existed. But they got their first chief of staff, they got some money allotted at the beginning of 2022, and poof, they had a program. It is basically identical to the DRA, right down to the forms that they use and the attestations that they use. Slightly different is that SCRC dropped a print ad requirement. It can all be internet advertising or emails to the medical schools. But they did keep a $3,000 filing fee that DRA recently, in the last couple of years, dropped. It includes all of Florida, which is fantastic, and parts of Alabama, Georgia, Mississippi, North Carolina, South Carolina, and Virginia. It is it's particularly great for Florida because Florida uses all of their waivers very quickly. They always get more than 40 applications for their 30 slots. So that helps that pipeline. Also, they've had some recent changes in that state health department that their program is a little fussy, if you will. And Georgia and North Carolina, it's also a great source to divert from them because they used to fill up pretty frequently as well. And then just very briefly on the Northern Border Regional Commission, it is, again, like a carbon copy of the ARC, like the SCRC copied DRA, the Northern Border, which covers New York and then Vermont, New Hampshire, and Maine, but primarily it's for the benefit in New York, is modeled after ARC, except for right now, while they get their feet wet, they're sticking with primary care, but they hope to expand to specialists. So, and I put this on here not to give anyone false hope, but there are 3 other regional commissions that maybe in the next 5 years, if they get money and they have staffing that would be amenable to advocacy from healthcare employers and immigration attorneys to start their own programs, that would also help these other areas. The Northern Great Plains would be great. Sorry, that should be Minnesota, not Missouri twice. I apologize. Which would be fantastic. And some of these programs are quite different. The state programs are quite difficult, but they don't even have any money now, so they're not doing anything. The Great Lakes Authority, which just started last year, also no money allocated. They don't even have a website. And the Southwest border, they probably have other issues at the top of their list at this time. But I mention them because if those areas are of interest, kind of watch the space, if you will. And when there are opportunities to advocate for those agencies to have programs, then we'll let you know. So just want to mention that. I'm always hopeful, even after doing this for this amount of time. Okay, so now you know kind of the programs, the lay of the land, if you will. Here are kind of the steps I think that would be healthcare leaders can successfully navigate J1 waiver process. So I'd like you to consider these steps in kind of partnership with Immigration Council. And one is to strategize. Determine which programs you're going to focus on, what specialties might have an applicant pool that skews towards foreign physicians, and where do you have the greatest need. Identify if your facility or facilities are in HIPSAs and NEAs, or if they treat underserved populations, or if you think that they should be designated as HIPSAs or NEAs. There is a process to compile data. There are organizations that will help you compile data to make a case to HHS that a designation is warranted. So you don't always have to rely on the State Department of Health to send that data in. There is a process. So which IGA programs can you use? That may be the point number one, to see what's available. And knowing which programs is there anything that you need to clarify with those programs before you start this road? For instance, what is their policy on telemedicine? Can you recruit a J1 waiver radiologist that will review films remotely, right? So those kinds of issues come up, and if you can kind of clear them up beforehand, all the better. and to develop an immigration policy. Actually, I tell all clients, whether they're healthcare or not, that they should have an immigration policy that helps with the recruiters know what they can and cannot hire and what they can promise. So will you consider sponsorship? All openings or only those that have been open for a certain period of time? What will you offer to the physicians to get them to come and get them to stay? Given the ever increasing shortages, healthcare employers must consider providing additional incentives, such as sponsorship for green cards or assistance for families to remain competitive when many of the best and brightest candidates are going to be foreign national physicians. Then develop your recruitment plan, which may differ from what you are typically doing. So based on when you can file waivers at the agencies that you have access to, kind of back up and start at least 9 months before filing, or for rolling filing, so the federal programs, maybe 18 months before the summer that they would start. Obviously, sooner the better, but those are general guidelines. Know your waiver programs for recruitment requirements, so you can do any of that special atypical recruitment, like reaching out to medical schools and residency programs. This is what I always like to advocate for the physicians, but you also have to make sure this is a 3-year commitment on both sides, right? Some of the programs don't allow you to have a no-cause termination clause or have a probationary period. So this is, again, a 3-year commitment. Make sure that it's going to be a good fit for the physician and your health system. And just like a recruitment team that has a good knowledge of the immigration process is to ensure that candidates understand the commitment that is required for the J1 program and that they have the right information and reasonable expectations as to the process and timeline. I think educating the foreign nationals on the immigration process, a lot of them have friends and they get information from friends. That is like a teen getting, sex education information from their peers. Sometimes it's good and sometimes it's horrible. So providing them healthcare with an immigration attorney to provide them with the right information is kind of critical from the get-go. Next, your agreement. Know what your program's contracts do and your program's do and don'ts are, and work with immigration as well as your labor and employment council to adjust your agreements accordingly. I like to, so that the physician has enough time to really consider the requirements and consider the contract and the commitment is, again, it just needs to be signed before filing, but I would say 2 to 3 months in advance would be great for a physician review. And again, these are just ideal times. And then preparation. So do you require community support letters? Can you identify possible letter writers ahead of time? Can you gather payer mix and demographic information ahead of time? And post the sliding fee scale if you know that you may need to have it posted. And finally, submit, early but not too early. So general rule is, 10-1 or late in the fall would be great for getting them on board and working in the summer. But you don't have to file too early. If someone's going to be joining you in July 2025, now is a little bit too early, maybe in the summer to start putting stuff together. So again, kind of these are general guidelines. Because a foreign physician recruitment program where you have institutional processes and procedures to identify the right candidate and kind of get through the J1 waiver process successfully, it will have long-term benefits. And I don't want to ignore retention and support. The anecdotal information is that foreign physicians tend to stay even longer than a 3-year commitment, but that whether they do is is key on your side. So once they have their waivers and they're beginning practicing, offer them support and resources to integrate them into the healthcare team and the healthcare community. And this can be mentorship programs, cultural sensitivity training, and assistance with visa and immigration issues. Let's see here. Do we have a lot of questions? I think we have a little bit of time to just talk about the changing from J1 to H1B. So again, as I mentioned earlier, the timing is, okay, I'll actually just answer this question for Mary now. You could have a signed contract. So the question, I'm sorry, is that the question is if you have can you have a signed contract now for 2025? Yeah, you could, and I've had clients do that, but HHS is not going to want to see that application filed until October. Early on, they actually didn't want any applications filed before December, but now they will allow October and later. So you can do the planning, but the filing, even for those that have a rolling process, it's probably a little bit too late. I mean, too early. All right. And I know I said we're going to save questions for later, but it pops up and I just can't. Sorry, Kelly. Sorry, Kelly. Yeah, and again, there was a question about telemedicine positions, and that's going to vary from program to program. And that's, there are some programs, HHS, one of them is they are telemedicine agnostic. They don't have a policy on it, so presumably you can file, but states might have other restrictions and information. And HPSAs and MUA for addresses. Okay, I might have to talk a little bit more offline or afterwards about telemedicine, because that's kind of a whole other ball of wax on how that's treated. So, okay, back to the program. So changing non-immigrant status from J1 to H1B. So again, the J1 just gets rid of the waiver, gets rid of the 2-year home residence requirement. You have to file a petition for H1B status. And it happens near the end of the J1 waiver process, again, between when the DOS issues a recommendation and the USCIS issues its approval. And it has to be H1B. The regulation provides that the 3 years must be in H1B status, no other status. So O1, green card, nothing. Or employment authorization card, I should say. Unfortunately, all physicians granted physician waivers are personally exempt from the H1B cap. So it doesn't rely on the characterization of the employer. They're personally capped exempt. And as a result, these physicians may commence work as soon as an H1B petition is approved without regard to the H1B cap, whether the H1B cap has been filled for the fiscal year. This is a great piece of information, is that the cap exemption extends even after the waiver period is fulfilled. So my kind of pro tip, I love telling recruiters, and I know there are a lot of recruiters on the call, is that for cap subject employers, physicians during the end of their J1 waiver obligation are great candidates because they don't have, they're exempt from the H1B cap. And the only other consideration when filing the H1B from the change of status from J1 to H1B is licensure. And this is sometimes where it can get a little tricky. Most are going to have their license if they file for it in the fall before they file the waiver application. They're going to have their license in the spring. But there are some states, Missouri, for instance, that won't approve licensure until the training is, till 3 years of training are complete. So for your primary care, it's going to be approved sometime in July as opposed to before the end of the program. So there are some issues with that. Usually they're overcomable. There are other states like Tennessee that do this kind of chicken and egg deal where they won't approve a permanent license without the H-1B. And so typically immigration will just issue a 1-year H-1B. so they can get the license, and then you turn back around the next year and file for another 3-year H-1B. So those are kind of tricky issues. It's usually a very straightforward process. I just want to mention some tricky issues, but know that there are solutions to almost all those issues when it comes to licensure. And I'm going to talk H-1B to H-1B in the next webinar. And my final thoughts are, like, don't be afraid of recruiting foreign physicians. I don't mean that in a, like, don't be xenophobic. That's true too. But also, these are U.S. clinically trained physicians. And again, as I mentioned earlier, they're more likely to stay within the health system that petition for them. So they're great gets. But the key thing is to create a strategy for recruitment and retention and kind of advanced plan so you know your options, you know your requirements, and you know your timeline. And then, so in future webinars and plus whatever you suggest, we'll look at like stopgaps when J-1 waivers aren't available or when H-1Bs aren't available, change of employer both during the J-1 waiver process and obviously from H-1B to H-1B afterwards, the green card, which is a key thing. And then I want to devote a whole webinar to nurses and allied medical professionals because, you know, they're a key part of filling this healthcare shortage gap. And throughout the year, provides you with information on how you can advocate for more healthcare immigration. Because I like to think of healthcare immigration as less immigration and more healthcare access, because it's so important for in all parts of this country. And let's see here. And we'll get to questions. Let's see here. So for any J-1, any recommendations on handling termination for performance and then handling extenuating circumstances. So again, that's one of the things that I want to cover in future webinars because it's a lot of detail specific. Sometimes it's negotiating how that termination looks, but how USCIS treats changes within that 3 years. Sometimes it's cyclical, sometimes they're very easy, sometimes they get really tough. And it just depends on the type of case that you can show as to these extenuating circumstances. And that may be Greek to some of the people because we didn't really cover extenuating circumstances, but that is in 3 years, there's no changes unless there's something outside the foreign national's control that rise to the level of extenuating circumstances. Like a clinic closure, that's pretty obvious. There might be a spouse that gets a very rare fellowship that's only offered in Oregon, so there needs to be a family move. Clients that may have a spouse that that's going through some health or emotional issues that they need to be close. So there's various different issues that can lead to changes during those 3 years. But again, I would like to go more into depth in the other webinar about that because that involves both the foreign national and healthcare employers. Is there yes, at the top of the program, we talked about the CLE credit, and there's an icon near the bottom of your screen to allow you to do that. But I have some Indian housekeeping. If there are no other questions, some finishing housekeeping issues. As a reminder, this program has been approved for legal education hours, so you can click on the CEU icon at the bottom of your screen. You'll get a certificate of attendance with your course number tomorrow, along with a recording of this webcast. And please be sure to complete our short survey at the end and let us know what you'd like to see in the future. And have seen no more questions, I'm going to say that this concludes our webinar. Thank you and have a terrific afternoon. Thanks for joining. Bye.